If you have knee arthritis, it's a good chance you may have heard new injection Arthrosamid. You may have read about it, or you may know someone who's had the injection, or your GP may have told you about it, or one of your physios. You've probably tuned in today to find out, does it work? Is it worth the cost? Will it prevent you needing a knee replacement for your knee arthritis? Or is it just another knee injection that promises a lot and doesn't deliver? Hi, I'm Dr. Arj. I'm a consultant knee and hip orthopedic surgeon. I work in London in the NHS and in private practice, and I've been doing orthopedics for about 25 years now, and I've been a consultant knee and hip surgeon for 10 years. So I want to answer your questions about Arthrosamid as clearly and honestly as possible, using my own experience as someone who initially didn't use the product and then has started using it over the last few years, and also using the current research evidence out there to help answer the question, does it work? How long does it work for? Is it safe? Is it cost effective? Who should have it? Who maybe shouldn't have it? So what is Arthrosamid? In simple terms, it's a gel. It's actually called a hydrogel. It's actually mostly water, but it also has something called polyacrylamide, which means it's a water-based gel. It works differently from another gel called hyaluronic acid. That's more of a lubricant that sits in the joint, eventually is broken down, but sometimes your knee is stimulated to produce more hyaluronic acid. This is different. This is essentially permanent. It gets absorbed, or it coats the inner lining or inner skin of your knee called the synovium, becomes part of that tissue. That tissue is what's often responsible for causing pain and inflammation. So it sits on that tissue and helps it behave in a less inflammatory manner. So the reason it can last a long time, many years currently in most patients, is because it integrates into the tissue of your knee. It's not just floating around in your knee, and it doesn't, as far as we know, get broken down. Different to other injections in that currently you only need one of these treatments. It doesn't need to be repeated. So often when I'm doing hyaluronic acid injections or corticosteroid injections or platelet-rich plasma injections, often they are repeated every 3 to 6 months sometimes, or annually, depending on the patient and the clinical scenario. It reduces pain by integrating into that synovial lining, reduces inflammation, calms down irritation in the joint. It's a fairly thick, viscous substance, so it has a degree of shock absorbing effect within the joint. So it's essentially a biological cushion, but its main effect is in how it helps your knee react differently to increased stress and load. That's associated with breakdown of cartilage and meniscus tissue, which is the padding in the knee. I've got another video where I go in depth on the other types of knee injections, but briefly, steroid injections are anti-inflammatory. They're very good for an acute flare-up of pain and swelling in your knee. It's probably good to not have too many of them. I normally don't give patients more than 2 or 3 per year, just because steroids can have a systemic effect on the rest of your body, because your body can also make corticosteroids, and they're very useful, but they have an effect on all areas. Normally when they're injected in isolation into the knee joint, any other effects outside of the knee are very minimal. And it's important that all your knee injections are given under ultrasound guidance, because it's much more accurate. I spent many years delivering thousands of injections without ultrasound guidance, and though many of them worked, maybe 10 to 20% of the injections were a little bit painful for the patient, or the patient didn't get the outcome they wanted. And I suspect it's because the medication maybe wasn't precisely going into the joint, may have been going into some fatty tissue or soft tissue within the knee. So ultrasound guidance is key. We talked about hyaluronic acid, which is a gel. I think it works very well in the patients I've used it on, and I've used it on thousands of patients over the last decade. However, the research evidence for it working is a little bit weaker. So anecdotally, patients I know are really happy with it. I feel it's best placed where someone has a knee issue where there's a need for a lubricant. So maybe they have crunching or grinding or catching. And in that scenario, it's often very helpful, and for early osteoarthritis, in my opinion. Platelet-rich plasma, I think, is very good and very promising. It needs to be given in the right dose. It's often harvested from your blood, and normally the more blood we take, the more concentrated the dose of platelet-rich plasma we can give back to you under ultrasound guidance. So it's very important you notice how much blood has been taken. It also depends on your own biology, how much inflammation you have, what your full blood count, and then particularly your platelet count is, how hydrated you are, whether you have any other medical conditions, whether you're on anti-inflammatory medication. So this all kind of affects your blood, and in turn affects how much good proteins and growth factors and platelets we can harvest from your blood and then in turn inject back into you. It's very promising treatment. Initially, when I was training, I was told it wasn't very effective, and some of the early evidence backed that up. But there's some good evidence now that suggests it can be very effective, in particular for tendon treatment, for treatment of injured tissue, and also now for treatment of osteoarthritis in the knee in particular. So does arthrosis work? The short answer is yes for most people, according to the current evidence, but not for everyone. There have been several clinical studies now. The most notable ones are the DAISY trial and the ROSA trial. They are randomized controlled trials, which are the gold standard in research, where patients are randomly allocated to either one treatment or another, depending on what we're studying. The patients often don't know what they're getting either. The LUNA study compared arthritis with physiotherapy, and the results show that combining the treatments was better than each treatment in isolation, which backs our OrthoLongevity philosophy, which I've talked about in another video about what is OrthoLongevity, and certainly combining treatments such as strength training, movement, optimizing your nutrition and your biology really helps these injectable treatments work. So we're going to have an injection, whether it's Arthrosamid or something else. You need to get everything else in order for you to be having the highest chance for these injections to be successful for you. They're not really, in my opinion, treatments in isolation, and neither is surgery. We have to do our bit, but you have to do yours. 5-year data from these studies shows the majority of patients have a significantly reduced level of pain in their knees compared to most. Normally, it's about 80% of patients do really well, and 10 to 20% of patients don't have a great result or are non-responders and don't feel much benefit. Patients don't normally need a repeat injection. There are some early patients who've had the injection a few, maybe 5 years ago, and some of them are having a top-up dose. But ordinarily, we wouldn't expect you to need this. There was a trial called the ASIG trial, ASIG, and that showed patients who did the best with Arthrosamid injections were slightly younger, so 45, 75, and they often had slightly less severe osteoarthritis, so mild to moderate wear and tear of the cartilage and meniscus in their joints. So I think if you're an older patient over 75 with severe osteoarthritis, where the joint is fairly destroyed or fairly deformed, or you have significant limits on range of motion, it's worth considering, but it may be less successful, and it may be worth thinking about other forms of injectable, or even thinking about considering surgical intervention like some form of knee replacement, in particular a total knee replacement, if the majority of the knee structure has worn away and you're finding it very difficult to move freely. Also, patients who have significant inflammation, so pain and swelling of the tissues, in particular with fluid in the joint, that often helps them normally do better, or is a good predictor of patients doing well, where previously I would have thought those patients would need corticosteroid first to calm down inflammation. The evidence suggests actually, though you may want to, as a clinician, remove some of the fluid from the knee first, that scenario works well for Arthrosamid because it acts on the synovial lining, which is mainly responsible for producing the inflammatory chemicals and fluid and for swelling up in your knee when it's aggravated. So in the OrthoLongevity approach, that I think about joint care in a sequence. So we use that repair framework that I've spoken about in my other video. So REPAIR. So R is reset biology, which means optimizing your nutrition, your sleep, your stress, helping any metabolic illness that you have like diabetes, so optimizing your glucose control and your insulin resistance. E stands for enhancing movement, which means getting that range of motion back with physiotherapy and osteopathy, ensuring that you have a stable joint. And then P stands for power, which means strength training, and that's really important. It's sometimes really difficult when you've got severe osteoarthritis. So within reason, we do want you trying to get that joint moving and trying to get those muscles strong in the gym if possible. But if not, then we go to A, which is augment healing. And that's where injectables like come in. So that's when I'd use it kind of after you've tried the other steps we've just mentioned, but before we go to surgery, which is intervene surgically. And then to prolong your result, whether you need to have injections or surgery, we want to build in the final R of repair, which is resilience, which is to keep you in those good habits lifelong, so you don't need to come back again, and that your other joints are also protected. We've also realized that if you have isolated arthritis, in particular at the front of the knee, so some people have osteoarthritis or wearing down between the patella at the front of the knee and the front part of the femur bone at the end of your thigh. Sometimes you get rubbing there when you bend your knee and put weight on it. If you're going up the stairs, if you're kneeling, if you're coming down the stairs, if you're squatting. So some people have degenerative change in that area, but the rest of their knee between the tibia and femur or thigh bone and shin bone is fine. So if your osteoarthritis is mainly between the patella and the femur, Arthrosamid has in recent studies been shown to be very positive for that. So that's a new development. So what does the procedure involve? So absolutely needs ultrasound guidance. It's really important that this injectable is put into the right place, into the joint cavity and not into any of the softer tissues in your knee. So your knee has synovial lining. It's got fatty tissue and fatty pads in it. It's got meniscus and it's got ligaments. The injection should not go into any of those structures. It needs to go into a space. So you need someone who's an expert at doing ultrasound and ultrasound guided injections to do that. You also need tablet antibiotics. We treat this like an implant because it's something that doesn't dissolve away. So when you have a knee replacement or a hip replacement, we give you antibiotics on the day of surgery to reduce the risk of infection. And likewise, when you have an Arthrosamid injection, you need antibiotics. They're normally tablet antibiotics that you have on the day of the procedure. And I normally give my patients a prescription so they can pick them up and then take them on their way to the clinic to see me. The injection, unhelpfully, is currently a 6 ml injection, which doesn't sound like a lot, but the company make the injection in 6 1 ml syringes. So you end up basically having 6 injections. How it's done depends on your practitioner. I tend to use some anesthetic to numb the area around the knee before I do the scan the knee properly. And then I put the 6 injections in sequentially, slowly into the knee and do it like that. So I feel it's more accurate. Some clinicians will put one needle into the knee and leave it there and then kind of unscrew each syringe and screw them on again, leaving the same needle in. I guess it doesn't really matter how it's done as long as it's comfortable for you and it's done accurately and the clinician's sure that the needle is staying in the correct spot. I would say the injection does take a little bit longer than most of my other injections because it's quite a thick substance. So we inject it very slowly into the knee. It's normally very comfortable, but it can feel a bit strange having this thick gloopy material injected into your knee. And I find that most patients are not too bothered with the needle going into the knee because often it's quite a small needle and it's often under local anaesthetic and under sterile conditions. But I do feel that the substance going into your knee is a bit uncomfortable. It probably feels a bit unnatural. And afterwards also, I think the knee can get a bit inflamed and react a bit to this product. So sometimes for the first 48 hours, I advise to take some anti-inflammatories or having some ice packs on the knee, keeping it gently moving, maybe using a static bike so you don't look too stiff, and then waiting hopefully for it to work. Arthrosamid isn't a quick fix. It takes many weeks to work. On average, most patients don't experience significant benefit till about 3 to 6 months after the injection. We normally find if you haven't had much benefit after 6 months, then unfortunately, it may not work for you, and that may be where you're at. I wouldn't judge the treatment at 6 weeks or before because studies show that it can still work after 6 weeks. It is an unusual product like most injections. They aren't always a guaranteed fix, and sometimes the outcomes you get are different. For instance, I had one patient, we injected her knee. She was really happy with the result. 4 months later, she came for the other knee to be injected because she had arthritis in both knees, but the second injection didn't seem to offer her much effect. So she was naturally very disappointed and is now on the waiting list for a knee replacement. So that kind of explains, how sometimes they can work and sometimes they don't. But overall, you have an 8 out of 10 chance that you're going to get a really, really good result, especially if you're 75 years and under and you have mild or moderate osteoarthritis or osteoarthritis in the patellofemoral joint. And also, if you do everything you can to improve your nutrition, so it's anti-inflammatory, reduce your weight, increase your muscle mass, improve your sleep quality and duration to 7 hours or more, and reduce your stress levels, then you're going to do better. So what if it doesn't work? Certainly financially, it's a hit. At the moment, these injections are not funded by the NHS or, as far as I'm aware, insurance companies. Certainly in London, where I work, they normally cost between £2.5 to £300 for the treatment. So it's not cheap, but if you're self-funding treatment where knee replacements sometimes cost between £12,000 to £20,000, if it works, it can be cost effective and obviously it saves you having surgery. If it doesn't work, however, very rarely you have an actual complication. It's more just incredibly disappointing. If you don't get a good result, as far as we know, there's no downside to having the Arthrosamid in your joint. You can certainly still have a knee replacement afterwards, even though some surgeons aren't aware of that. It's very safe to do that. You could also consider other injections, which can still work after you've had an Arthrosamid injection. So the bridges haven't been burned. so don't worry too much. So before you go, 3 questions that all patients should ask before you have any sort of injection into your knee. Number 1, are you the right candidate from your symptoms, your age, the pathology that's happening? Because all the 4 injections I described, corticosteroid, PRP, hyaluronic acid, arthrosamid, are all used, in my opinion, for slightly different reasons, or all have slightly better benefits and risk profile depending on exactly what's wrong with your knee. So make sure that you fit the injection. 2, is it part of a proper plan? You shouldn't just be having an injection in isolation by a practitioner who's just interested in doing the injection. You need to be treated holistically because you're a complex individual. We need to work on the other aspects of your care that will help the injection be more successful, which I mentioned before. To summarize: sleep, lower stress, high protein, good nutrition, whole foods, lots of hydration, all the nutrients you need, weight management in terms of less fat, more muscle in the gym, even things like being social and avoiding social isolation. All of these things affect how much we feel pain and how inflamed our joints can get. And often, if you can get on top of these things, even if you have wear and tear in your joints or bone-on-bone changes, like some of the clinicians might tell you, they don't always hurt. That's the key. 3, what's the backup plan if this doesn't work? Again, your clinician should have a backup plan. So we always know what we're going to do if it doesn't work. And I always have a plan for my patients. I'm always very pessimistic and I assume things won't work. It's my job to do that. And then I have to have a next plan to get them back to everything they enjoy. So make sure that your clinician can answer those questions. Okay, so that's a video about arthrosamid. Leave your questions in the comments. I read and answer all of them. If this was useful, please share with someone who has knee osteoarthritis or might be thinking about having a knee replacement or has been told they need a knee replacement and maybe is keen to try and avoid it. Take care of your joints. They're worth it.